Good afternoon, dear audience. My name is Maria Bucur. I am pleased to present to you my progress with my PhD thesis entitled Diabetes Mellitus across pancreatic diseases. I'm a fourth-year diabetology resident doctor in Romania and also a PhD student in a bilateral contract between Carol Davila University of Medicine and Pharmacy in Bucharest and Central of Translational Medicine here in Budapest. For my PhD, I have two specific goals. First of all, I would like to understand how to prevent diabetes, and secondly, how acute pancreatitis influences the beta cell function. Let me introduce to you now my first project, which is investigating therapeutic options for preventing or delaying diabetes mellitus in prediabetic patients. And we chose a systematic review and a meta-analysis to perform this investigation. So prediabetes is the term used to describe patients whose glucose levels are above the normal range, but that do not meet yet the criteria, the diagnostic criteria for diabetes. And as you can see, over 470 million people will have prediabetes by 2030, and moreover, 5 to 10% of them will progress to diabetes mellitus yearly. Currently, the American Diabetes Association recommends that we implement lifestyle modifications to lower this risk of progression or to add metformin for a specific population. But on the market, currently we have available newer drugs, such as the GLP-1, who are used to treat obesity. And in this context, we are asking ourselves which is the best treatment to use for the prediabetic population as well. So we raised this question, and we want to investigate adult prediabetes patients that are given any type of intervention and to examine the diabetes incidence and the changes in hemoglobin A1C, fasting plasma glucose, or in the oral glucose tolerance test. And we want to include only randomized controlled trials and to perform a network meta-analysis in the end. And we hypothesize that lifestyle modifications are followed by a greater risk reduction than pharmacotherapy. Using the following search key, we searched 3 major databases, and we started with more than 2,000 articles. And after the flowchart of selection, we ended up with almost 350 articles. We had a total of 11 outcomes, the most important one being the incidence of type 2 diabetes. The measure of effect for this outcome was the risk ratio. And for the continuous outcomes, we choose as a measure of effect the difference of means. Currently, we finished the analysis for the incidence of type 2 diabetes, and I would like to present to you some of the results. Here we have the network for the incidence of type 2 diabetes outcome. The circles represent the interventions, and as we can see, we had quite a lot of different interventions. And the weight of the circle means that there were a lot of studies in which that intervention was present. And as you can see, we had a lot of studies where control was used as a comparator. The lines between the circles represent the direct comparison between the two interventions, and the numbers represent the numbers of studies that had this particular direct comparison. In this forest plot, we can see the ranking of the interventions based on the risk ratios when compared with control. So the risk ratio is basically the ratio between the probability of developing the outcome, which is the type 2 diabetes, in the intervention group compared with the control group. And if the risk ratio is 1, it means there is no difference between the intervention and the control in preventing type 2 diabetes. And as we can see here, most of the interventions prevented type 2 diabetes, but as we can see, there's not much difference between the risk ratios between the interventions. The confidence intervals are almost quite overlapping. So the conclusion from here will be that there's not much difference between the interventions, and this ranking could also be due to some randomness, and this could explain why, for example, L-arginine, which is a supplement, it is above, for example, alpha glucose inhibitors, which are type 2 diabetes drug. Here, one of the advantages of performing a network meta-analysis is that we can also have indirect comparisons. And here I wanted to compare all of the interventions with lifestyle intervention, which is recommended by the American Diabetes Association to prevent type 2 diabetes. And here we can see that only the association between metformin and lifestyle and thiazolidinedione plus intensive lifestyle perform better than the intensive lifestyle by itself, but without statistically significant results. And when we compare all the interventions with metformin, we see that slightly more interventions perform better, but again, we don't have statistically significant results. From the continuous outcomes, I chose to present to you the hemoglobin A1C, which is a blood work that shows us the glucose levels of a patient in the last 3 months. And I wanted to present to you 3 of the interventions: the GLP-1, metformin, and intensive lifestyle intervention. And the measure of effect is the difference of mean differences. And when we compared GLP with placebo, we obtained a difference of mean difference of 0.25, which is clinically significant and also statistically significant. If we look at metformin versus placebo, we see that at 6 months we have a clinically significant mean difference, but this effect at 12 months is diminished. Although these results are not statistically significant. When we compared intensive lifestyle intervention with conventional lifestyle intervention, we did not obtain a clinically significant mean difference, although the result is statistically significant. So our study is the most comprehensive meta-analysis on the topic so far, and we investigated new drugs on the market by using a high-quality methodology, but we faced quite a lot of limitations, such as the placebo or control frequently being used as a comparator, the high heterogeneity of the interventions, meaning different durations of follow-up, different posology of the drugs, and different definitions of the interventions, such as intensive lifestyle intervention or lifestyle intervention. We can have some preliminary conclusions with these results, and that will be a combination of intensive lifestyle intervention and medication seems to perform best, that GLP-1 agonists reduced hemoglobin A1C by clinically and statistically significant level. Metformin reduces hemoglobin A1C by clinically relevant levels only at 6 months, but not after 1 year, and an intensified lifestyle intervention does not perform better than unusual lifestyle intervention. And from this, we can implement in practice that there is no large difference between possible treatments. Long-term routine administration of metformin is not justified, and usual lifestyle intervention can be recommended instead of an intensified regimen. As the implication for research, we need further studies in order to look at dose dependency and longer time of administration, and further studies to have direct comparisons between different interventions other than control or placebo. So my progress with the first project is that I'm still waiting for results, and I wrote only the introduction and methods of the manuscript. And moving forward, my second topic is investigating the time dependency of beta cell function failure during acute pancreatitis. This time will be a registry analysis. And I would like to invite you to imagine a clinical case. We have a female patient that presents to the emergency department with acute abdominal pain. She has pancreatic enzymes 3 times higher than the normal ones. And by performing an ultrasound, we can establish the diagnosis of biliary acute pancreatitis. And moreover, she has a blood glucose level of 250 milligrams per deciliter. And it is important to treat her blood glucose levels because we will see that they are dose-dependently associated with severity and mortality. And we still have no recommendations in the guidelines regarding insulin treatment. As I said, stress hyperglycemia is seen in more than 50% of the cases. Organ failure is also seen in 20% of the cases and is mostly reversible. And although the major organs have been widely investigated, there is scarce data on the beta cell function, which is exactly the aim of our study. And we can evaluate the beta cell function either directly by using the C-peptide levels, or indirectly by the total dose of insulin needed to keep the blood glucose levels in the normal range. So we raised the question, what is the time dependency of beta cell function failure? And we want to investigate adult patients and to look at their glycemic levels during the course of admission and to evaluate the need for insulin administration. And we hypothesized that there is a time dependency in insulin necessity, meaning in the early phases we have a higher insulin necessity, and in the late phases there is a low insulin necessity, and this correlated with the CRP levels. And by doing so, we can understand better the dynamics of beta cell function, and we can provide based evidence recommendations for treatment in AP. We want to use the AP registry, and we are currently still gathering data. We have a total of 680 patients receiving insulin. So to sum up, I have still 2 ongoing projects that I hope to finalize by the end of this year, and I'd like to thank you for your attention with the quote, "Medicine is a science of uncertainty and an art of probability." Thank you.
Thank you very much. Any questions from the floor?
Congratulations.
Thank you.
What is considered intensive lifestyle intervention and what is just regular intervention?
Yeah. So it was quite challenging to make these groups. Intensive lifestyle means that patients were monitored more frequently. They were provided either a gym membership or a pedometer or something that can keep track of their physical activity, whereas in the usual lifestyle they were just given basic recommendations and they were not provided with pedometers or gym memberships. So the assessor were not able to estimate how much of the physical activity or diet they were actually following or doing during the course of the year trial.
Anything else?
Another term that finally, what was the definition of prediabetes? You didn't mention that.
Well, we used the American Diabetes Association criteria, which they use either the hemoglobin A1C between 5.7 and 6.4, or the fasting plasma glucose between 100 and 126 milligrams per deciliter. I'm sorry, I don't know the millimoles. I know here in Hungary you use millimoles. Or the oral glucose tolerance test and the 2-hour plasma glucose after the test, that it is between 140 and 199 milligrams per deciliter. And we had studies where the patients only had, for example, impaired fasting glucose. We had studies where they had impaired glucose tolerance, or studies where they had both. But we did not do any subgroup analysis based on this, because in the study itself, they were not given the information separately. But I suppose it influences the results, yeah.
Anything else?
Congratulations, Maria. You had a really large pool for your first project. I have a question regarding to your second registry analysis, because you mentioned that there are no recommendations currently about the route and the dosage. You would like to investigate these as indirect signs of beta cell functions.
Yeah.
Were there any protocols in those departments where they enroll the patients in the EP registry?
Protocols for insulin treatment?
Yes.
No, as far as I know, and from the data that we have so far from the registry, we have subcutaneous administration, pump administration, so intravenously. So we have rapid-acting insulin, long-acting insulin as well. So it appears there is no protocol that's been followed. So this is exactly what we are trying to do, to see if we can establish a protocol for insulin administration in order to prevent hyperglycemia but also hypoglycemia, because in subcutaneous administration it appears to be a high risk of hypoglycemic events, and they also make the necrosis worse in the pancreas.
Okay, thank you.
Thank you.
Just back to this question, I hope that long-acting insulin was not administered in these cases, like since it's an acute disease, and of course the short-acting insulin is really recommended.
Yeah.
We will see the result.
And we will evaluate also the patients who had diabetes prior and the ones who don't. So we can also see how this acute pancreatitis modify their need of insulin.